So now let's talk about anticoagulants. So anticoagulation is part of the treatment for myocardial infarction. Before we talk about anticoagulants though, it is very important to distinguish the difference between platelet aggregation inhibitors and anticoagulants, because sometimes some people use them interchangeably. And in order to fully understand the difference between anticoagulants or anticoagulation versus platelet aggregation inhibitors, we have to understand what happens in clotting. This is an illustration or a more general step of clotting. This is on the left side over here. So first it starts with an injury. So a blood vessel is severed, there's something going on. We have white blood cells, red blood cells, and platelets going to that area of injury. And afterwards, because of the injury, that causes some vascular spasm. So the smooth muscle in the vessel wall contracts near the injury point, thus reducing the blood loss. Following that, there's the platelet plug formation. So platelets are activated by the chemicals released from the injury site and by contact with underlying collagen. So then when the platelets are activated, they become more sticky, so they start like sticking together, forming a platelet plug. Then the coagulation cascade happens. So this is when there's a formation of clots. So in coagulation, in general, fibrinogen is converted to fibrin, which forms a mesh that traps more platelets and erythrocytes, producing a clot. And so if you can see over here, these are fibrin strands which secure the platelets and erythrocytes, effectively plugging the break. So basically preventing more damage, preventing more blood loss. So this is the general clotting process. And on the right side, we have the clotting cascade. So platelet aggregation inhibitor, it does not affect the coagulation cascade. So what it affects, where it happens, is actually in the platelet plug formation step of coagulation. Now anticoagulants, on the other hand, affects the clotting cascade, so the coagulation process, and this is the more detailed coagulation cascade over here. So the anticoagulants affect certain steps on the coagulation cascade. Now you'll also learn about fibrinolytic or thrombolytics, which breaks existing clots, which neither the platelet aggregation inhibitors or the anticoagulants do. So they don't break existing clots. And we're going to talk more about that. I know it can get kind of confusing, but I just wanted you guys to know that there are differences between platelet aggregation inhibitors, anticoagulants, and thrombolytics. So the mechanism of action of anticoagulants, in general, it exerts action in the clotting cascades. The therapeutic effect is it prevents clot formation. Indications for anticoagulations include CAD, MI, heart failure, heart valve replacement, history of thrombotic stroke, DVT or deep vein thrombosis prophylaxis and treatment, and as well as pulmonary embolism for both prophylaxis or treatment. Some precautions would be when it comes to patients with blood dyscrasias or clotting disorders such as hemophilia, as well as recent surgeries, concurrent use of other drugs that can affect clotting. Some contraindications, so pregnancy is contraindicated depending on agents. So there are going to be agents that are safe to use during pregnancy, and there are going to be agents that are absolutely contraindicated for pregnant women. And lastly, another contraindication, since we're talking about anticoagulants, so if somebody with active bleeding, either visible or occult, that's a contraindication to use anticoagulants. Side effects of anticoagulants include bleeding, nausea, vomiting, hypotension, cardiac dysrhythmias, thrombocytopenia, and some patients can also develop HIT or heparin-induced thrombocytopenia. So HIT is an immune complication of heparin therapy caused by antibodies formed after administration of heparin. Some nursing actions when patients are receiving anticoagulants. So one is continual or continuous assessment for active bleeding, either visible or occult, and also appropriate drug dosing, especially with certain medications. And it is also very important to monitor and analyze labs such as the CBC, hemoglobin, hematocrit, and also including the platelets. When it comes to patient education, again, it is very important to talk to the patient, make sure they are understanding the treatment, dosing, labs, and safety issues, and when to call. Especially with anticoagulants, it's very important to prevent patients from falling. So educating the patients to call, to not get up without anyone's help, to ensure that the patient doesn't end up with bleeding complications from a fall. Some examples of drugs in this class or anticoagulants are Coumadin or warfarin. So the form class for Coumadin is coumarin derivative. What it does is it inhibits vitamin K synthesis by bacteria in the GI tract and inhibits vitamin K dependent clotting factors. So it's given through oral route, and there are some dietary considerations, and it is also considered a pregnancy category X. Diet with warfarin, it is very important to educate the patient to avoid green leafy vegetables rich in vitamin K, as it interferes with the effects of warfarin if consumed in large amounts. So when it comes to dosages, Coumadin or warfarin is adjusted based on PT and INR, or using INR, prothrombin time, so how long it takes for the blood to clot within the extrinsic pathway. So depending on the patient's disease process, there is usually a goal INR level to ensure that the patient are therapeutic, or to ensure that we get the response that we want. Again, we monitor the INR level. So a normal INR level, we want it to be equal to 1. Now, what is considered therapeutic? So if we're giving Coumadin to a patient, the common range, so again, this can vary, but for our specific class, the therapeutic range is usually from 2 to 3.5. So what's INR? So INR is International Normalized Ratio. So this is used to monitor and adjust the warfarin dose based on those INR levels. A very important thing to remember is the reversal agent for Coumadin or warfarin in case of overdose, or in case of wanting to reverse the effects of Coumadin. The reversal agent is vitamin K. Another anticoagulant is heparin. Its therapeutic and pharmacological class is actually the same, so it's both anticoagulant. So heparin can be administered both in IV form and subcutaneous or sub-Q routes. IV dosages are based on PTT, and you'll also find out that some hospitals in town will be using a different dosing lab. Factor 10A is used in a local hospital here, so don't be surprised, but more commonly PTT is used for dosing heparin. So subcutaneous therapy is usually set dose, and we monitor the PTT for the drug effectiveness. PTT, oftentimes it's 25 to 35 seconds. So the goal PTT level is determined by the indication, the facility's protocol, and sometimes some doctors will order specific numbers, and it's basically to monitor the response to the anticoagulation. So PTT, or partial thromboplastin time, which pertains to the intrinsic coagulation pathway. If you're asked what's the reversal agent of heparin, this is something that you have to remember. So the reversal agent of heparin is protamine sulfate. Protamine sulfate binds to heparin and neutralizes it. Another anticoagulant that we're gonna be seeing a lot is Lovenox or enoxaparin. The pharmacological class of Lovenox or enoxaparin is low molecular weight heparin. So this is different from the heparin, right? Because the heparin's pharmacological and therapeutic class is anticoagulant. So for Lovenox, it is an anticoagulant, so that's a therapeutic class. However, its pharmacological class is low molecular weight heparin. So dosing for enoxaparin or Lovenox is basically standard and often weight-based depending on the indication of the treatment. This can be used prophylactically or to prevent clot formation, and sometimes as a treatment, for example, for DVT and for PE. It is also important to remember the reversal agent of Lovenox. Reversal agent of Lovenox would be the same as the reversal agent of heparin, which is protamine sulfate. Again, protamine sulfate binds to enoxaparin and it neutralizes it. Another anticoagulant that's commonly used is Eliquis or apixaban and Xarelto or rivaroxaban. These are factor 10A inhibitors, or sometimes also called factor XA inhibitor. Also, Pradaxa is also used. It's the bigatran etexylate. It is a direct thrombin inhibitor. So if we look at the coagulation cascade, this is where where the factor XA inhibitors act, or factor 10A inhibitors act. They got their names from XA, so apixaban and rivaroxaban. It inhibits factor 10A to convert prothrombin to thrombin, and thus inhibiting coagulation. Now, on the other hand, the bigotran or Pradaxa is actually, it works here in this step of the coagulation cascade. It inhibits thrombin, so it is a direct thrombin inhibitor. So that's all about anticoagulants. Next, we're going to be talking about fibrinolytics or thrombolytics. But before we proceed, I want to summarize the differences between platelet aggregation inhibitors, anticoagulants, and fibrinolytics. Platelet aggregation inhibitors works on the platelets. It prevents platelets from sticking together. And anticoagulants, they don't break down clots, but it does prevent clots. Fibrinolytics, on the other hand, even after the clot is already formed, it breaks down those clots. So I hope that helps with the differentiation of these therapeutic classes.